Scott Pierce, who is currently the Senior Vice President of BlueCare, Enterprise Operations at BlueCross, BlueShield of Tennessee. And he'll be discussing BlueCross, BlueShield of Tennessee's creation of an innovative program that's been designed to prevent NAS, known as the Mothers and Infants Sober Together program, or MIST for short. He'll also share how working collaboratively with the state and local communities is helping to make this program a success. Scott.
Thank you. My name is Scott Pierce, and I work for BlueCross, BlueShield of Tennessee. And we serve about 500,000 Medicaid and CHIP members across the state of Tennessee. And I want to talk to you briefly about this terrible social problem that we're dealing with in the state of Tennessee, and really our health plan's response to that problem. We asked ourselves a lot of hard questions when we really began to study this issue of NAS, and really I think it really became a question of identity for us. We had to ask ourselves, really, what can a health plan do to solve these very complex social issues? And I don't want to dwell on the problem as much as I do sort of some of the approaches we're hopefully bringing to the table to help Tennesseans. But I would say, I would also give kudos to our Tennessee Department of Health. Our two previous presenters have mentioned them, but our Department of Health has put together a very good surveillance report that really highlights the NAS problem in the state of Tennessee. Unfortunately, I think that report has really led us to an unfortunate milestone. In 2013, we had over 850 babies with a primary diagnosis of NAS. And I would say that that number is low, because I know that there's one fairly major county in the state that is underreporting. So I think just to give a lot of compliments to our health department, it really does highlight the problem that we're facing. And we as a health plan began to see the numbers in 2011. We started looking at our own data and saw a dramatic increase in our NICU costs. And just to give you some scope, we spend about $4,000 for the bundle of services that would be included in a normal delivery. If you have NAS as a primary or secondary diagnosis, the average is $67,000. And I would also say that that's probably a low number, because there, at least from my perspective, there's little understanding of the long-term cost associated with NAS. So the number that I'm reporting is simply the cost of the delivery and the subsequent NICU stay. But I think we as a society in general just know very little about the healthcare spending of these children as they grow older. It was fairly quick for us to discover the epicenter of this epidemic in our state. And we looked at our own data and found that East Tennessee Children's Hospital in Knoxville had seen a dramatic rise in their census in the NICU. And so we traveled to Knoxville, a group of us in leadership of BlueCare. We paid a visit, and we visited the NICU. And what we found at that NICU were rooms of infants suffering from NAS. They were being cared for in dark rooms with volunteer cuddlers, that's what they're called. And these are just citizens who had volunteered to help calm these babies. These babies cry constantly, they shake, and they require almost constant contact with people. So the hospital has created a great volunteer program where people can sign up to come and take a shift and basically rock these babies in these very quiet, dark rooms to try to calm them as best they can. And if you're ever in Knoxville, I would encourage you to sign up for a shift. It will definitely change your perspective on this. If you talk to the people that work in that NICU, they will tell you that the problem is not meth, but it's prescription painkillers. And if you talk to those mothers, most of them will tell you that their doctors told them that there was no way that their prescription drugs would affect their baby, which is incredibly wrong. And I know we have policymakers on the phone. We've got to, as a nation, get the word out that we've got to get a better message out to people who are in childbearing years and who are prescribed prescription painkillers. And we also really have to make sure that doctors understand that there should be consequences for prescribing these drugs in massive quantities. We also talked to the Department of Children's Services in Knox County. What happens to most of these babies as they are discharged from the NICU, they go almost immediately into state custody. And the census of children who are in state custody in Knoxville has risen dramatically over the last few years, almost extensively due to this issue. So let's talk a little bit about the opioid prescription rate in the state of Tennessee. And just to show you, this slide shows our state from 2007 until 2011, prescription rate per 100 of the population. As you can see, each year the red is bad, and that means that there are large quantities of prescription drugs opioid prescriptions being prescribed. As you can see, with each passing year, the state turns more and more red. I can't help but believe this is also going to tie into Dr. Patrick's chart that showed the dramatic increase of NAS babies. And just to go a little deeper on where the real epicenter of this problem is, the red again is bad. It shows the NAS babies per 1,000. And this is just our own health plan's data, but you see that it really is focused in that Appalachian region of East Tennessee. I visited large NICUs in Memphis, which is on the far west side of the state. They do not have this same problem, so it is very geographically focused for us in that Appalachian region. And just to go to slide 5, this shows East Tennessee Children's Hospital's census. And you can see over the years from 2010 up until the beginning part of 2013, just this dramatic increase of NAS babies at that particular hospital. So I think we saw the dramatic impacts of NAS at East Tennessee Children's Hospital, but the reality is that Children's Hospital does not deliver any babies at all. I think their CEO told me that the last delivery they had in that hospital was, years and years ago. So they basically are just taking transfers from outlying regional hospitals and their NICUs. So we had to do a little bit more research. Let's go to the next level of this and find out where are these NAS babies being born. And that led us to a community in Campbell County, Tennessee. It's a town called Jellicoe. And I'll give you just some of the demographics of that county. It's a population of about 40,000 in that county. It's right on the Tennessee-Kentucky border. And it's essentially an old coal mining town that the coal mining dried up years ago. And it's a very beautiful place, but there are not many economic opportunities in that community. And we found very few healthcare providers in that community, but the ones that we found are absolutely tremendous. And we really refer to them as heroes because they're out in those communities every day dealing with these problems. There's one FQHC, and then there's one very small hospital. And Dr. Thomas, who may be on the webinar, we owe a lot to him because he greeted us with open arms when we showed up in this town. Our data led us to this town, and we basically showed up unannounced at their doorstep, and we had one simple message: what can we do to help? And I think there was initial skepticism of what's an insurance plan doing here unannounced? This has got to be bad. But after they warmed up to us, we have formed very meaningful partnerships. And one of the things that Dr. Thomas told us is that he's basically the only prenatal care provider in that community. He sees basically every pregnant woman in that town. He also tests his expectant mothers for various drug use, and his research is very telling. And I'm going to jump to one slide here real quickly that basically reveals that almost 50% of his females who were in childbearing years, when we define that as ages 15 to 44, were actually using opioid prescriptions. So 50%. It's pretty staggering. So we wanted to do something about this problem, but we really had to ask ourselves, what can a health plan do? And there were a couple of strategies that emerged from that. The first thing that really became our obligation as a health plan is that we have connections all over the state as the largest insurance carrier in the state. We know every provider. We know the state government really well. How can we help build a coalition around this problem? And we began to look at the services that were available in these various communities. And we really came to the conclusion that one of the best things that we could do as a health plan was to try to encourage and persuade and do whatever we had to do to make sure that we could bring the needed substance abuse services to the communities who are in these rural areas like Jellicoe, Tennessee, and bring those services to places where they just historically had not existed. And so if you lived in Memphis or Nashville or Knoxville, you stood a pretty good chance of finding a substance abuse provider that could help you with your problem. But if you lived in a remote area of Appalachian area of Tennessee, you didn't. It just didn't exist. So we've started two programs. I want to talk about both of those. One at the Children's Hospital and one in Jellicoe. Both of those are really aimed at pulling providers of services, substance abuse services, to these communities. And we realize that they aren't necessarily going to prevent the NAS baby that we're dealing with at that point, but we hope to get the mother involved in treatment and hopefully prevent NAS baby number 2 and number 3. So I want to go over the details of those programs just very briefly, and I'm sorry I've skipped around the slides quite a bit. The first one is a program we started at the Children's Hospital, and we call it New Beginnings. And New Beginnings is an idea that mothers of these NAS babies are transferred to East Tennessee Children's Hospital, and what happens is they are usually confronted by a Department of Children's Services caseworker who is unfortunately has to deal with potentially placing that child in state custody. So we've worked with the Children's Hospital, with DCS, and with a local mental health, behavioral health professional facility in Knoxville called Helen Ross McNabb, which is a wonderful facility in Knoxville. And what we try to do is make contact with those mothers while their baby is in the NICU, and we have a very frank conversation with them about the reality of what might happen and what usually happens in these situations. We don't want to see the child go into state custody, and neither does the mother. And so we present a treatment path at that point in time and say, if we want to prevent this bad situation where the state might have to come in and become the legal guardian of your child, let's talk about what kind of treatment we can provide. And there are a lot of strategies that go with that conversation. And basically what we've done is we've talked to these mothers what would be useful to them in that situation. So we will feed them, for example. We will have meetings, and we will provide food. And you know, if any of you have been with a family member in the hospital, a good meal is very welcome. So we've tried all of these strategies. We offer them, they're called baby bucks, but they're essentially gift cards where they can use to buy things that they might need for the child once they get home. So we use all of these strategies to engage them in this conversation. The conversations might be heavy-handed about talking to them about what might happen in this situation with DCS, to warmer conversations about, hey, how can we help you with buying formula, etc. Children's Hospital has been great. They've given us some space to do this. And so basically what we did was we were a consensus builder. We pulled people around the table. We're also a funder. We are paying for the startup of these programs, and we have a lot of high hopes for new beginnings, and that is at the Children's Hospital. I want to talk to you about another program that we call MIST, and that is a program that we started in Jellicoe, Tennessee. And one thing I would say about that is most of the times when a health plan starts a new project, they traditionally go towards the big cities. That's where most of the providers are. That's where most of your members are. It's actually been very rewarding to start a program in a town that has not traditionally gotten a lot of attention. And so we had a kickoff for the MIST program last summer, and we had fantastic participation by our state government, our Department of Health, our Medicaid agency. We had providers, BlueCross was there, and basically what we did was put a stake in the ground in this small town on the border of Tennessee, Kentucky, that said we've got to really intervene here. And so what the MIST program consists of a case manager, a counselor, and a program manager who work together to support and care for the families who are struggling with substance abuse. The program is fully integrated into the operations of the FQHC in that community. And we, again, found a willing provider who was from the Oak Ridge area who was willing to come up to Jellicoe and offer services where they had just traditionally not served those communities. But the team connects with moms through a variety of channels. They perform home visits. They do individual therapy sessions. They do weekly support groups. Moms are welcome to bring their children with them. But again, the whole idea, sadly, we may not prevent NAS or NAS baby number 1, but we're really trying to intervene to prevent NAS baby number 2 or 3. And again, I started, what can a health plan do? I think the best things health plans can do is bring people to the table, convince providers to serve underserved areas, be partners with the providers who are already in underserved areas, make sure that you are not only a champion but also a funder. So we have committed about $290,000 to support the MIST program, and I would say that it's a huge uphill fight to try to solve the prescription drug abuse problem in this state. But we have lots and lots of people who are very interested and dedicated to this. But it has been tremendously rewarding on a personal and professional level to meet the people who are out there combating this every day. And again, if you ever get a chance to hear Dr. Thomas speak about this issue, you will be better off for that. So that's essentially what we're trying to do to combat this problem.